A very good afternoon and welcome to our session on the topic endometriosis and fertility. We are glad to have Dr. Sangeetha Anand among us today to help us understand the topic. The doctor will take us through that more in the session today. Also, if you have any doubts, any questions, put them in the comment section. Our doctor will answer all your questions and queries, but in the end of the session. So stay tuned till the end and have all your questions answered. Doctor, you have the stage.
Good evening, everyone. This is Dr. Sangeetha Anand, consultant reproductive medicine at Apollo Fertility, Brookfield, Bangalore. Today, I would like to talk about endometriosis. It is so common among the fertility population that I thought I would discuss about how it presents, what are the ways of management, how to give pain relief, and how we treat the patients with fertility issues. So, I would like to start with certain things. First, overview of endometriosis. How do we diagnose and how do we grade and classify endometriosis? How does endometriosis affect fertility? What is the rationale in managing endometriosis? What is the right choice of drugs for pain relief and clinical management of fertility? So, endometrium is the inner lining of the uterus. In the layman language, we can say it as a baby bed. Endometrium is the inner lining where the embryo implants and starts growing. The endometrium is a place where the baby attaches. If there is no pregnancy, the endometrium is shed as monthly period. So endometriosis is a condition where there is implantation of this endometrial glands outside the uterus. It's a chronic and recurring condition. It is characterized by the presence of endometrial glands as well as the stromal lesion outside the uterus. These lesions can be on the outer wall of the uterus, that's called the peritoneal lesion. It can be on the superficial layers or it can go deep inside the muscle layer or deep infiltrating lesions. It can be as a cyst in the ovary, that's called a blood filled cyst, called the endometrioma. So, when you look at the prevalence of endometriosis, about 10% of women in the reproductive age group suffer from endometriosis. The global prevalence is around 176 million. In India, around 25 million women suffer from this condition. So, there have been various theories put forward for the occurrence of endometriosis. Why does this occur? Why does the menstrual blood, which has to come out through the vagina, go back and get collected in the pelvic region? So many theories are there, but none of them has given a solid evidence that this is the reason. Some say it's a retrograde menstruation, some say it's an altered immunity, there can be a coelomic metaplasia, or a genetic component plays a role, or a stem cell. So many theories have been put forward. But one thing what we usually agree is the retrograde menstruation is the most predominant theory for the occurrence of endometriosis. These endometrial implants, because of the retrograde menstruation, they go and deposit on the superficial peritoneal cells. They get an increased vascular supply, they proliferate, they alter the immunity. There is an increased leukocytes, macrophages in and around the endometrial implants, and which causes the pain and the problems with endometriosis. Because of these abnormal implantation of these endometrial glands, there can be local hormones, cytokines, growth factors that cause a chronic inflammation. Because of the chronic inflammation, we get all the pain and associated symptoms. So these peritoneal endometrial lesions, they cause activation of the macrophages because these are the cells which release pro-inflammatory cytokines, reactive oxygen species, nitrogen species that can cause further proliferation of the endometrial glands, which lead on to chronic inflammatory lesion, hormonal imbalance, adverse pelvic environment, which causes adhesions, pain, and related issues, leading on to infertility. So, when you look at the signs and symptoms of endometriosis, it has a varied clinical presentation. Patients usually present with pain during periods. That is the most common symptoms you see in endometriosis. Some have pain during intercourse. Some may have intermenstrual spotting. They can have painful defecation. And as I said, of course, 30% of women with endometriosis land up with fertility issues. Some might even have painful urination. They might have a chronic pain in the pelvis. There can be severe menstrual cramp. So the clinical presentation can be so varied that sometimes it becomes difficult for the patient to identify whether it is related to the period, should she meet a gynecologist, or sometimes the pain presents as though it looks like a irritable bowel syndrome. Patient might present to a general surgeon. Painful defecation and pain during urination, hemoptysis, all these sometimes patients might present to a general surgeon. But most common symptoms will be pain during periods, heavy bleeding during periods, painful intercourse, and infertility. So, what are the risk factors? Which set of women are at risk of developing endometriosis? One is early menarche. That means if a girl attains our maturity early menarche, they found this as a risk factor for endometriosis. When there is a shorter menstrual cycle, who bleed earlier than 25 days cycle, there is a risk of endometriosis. Second, advanced age. When there is long period of menstrual cycles, so she has been getting her menstrual cycles for a long period, advanced age, they are at risk of endometriosis. And heavy flow during periods. Second, there is a genetic component. When there is a family history of endometriosis, lean body mass index, and pain during intercourse, all these have been found to be a risk factor for developing endometriosis. Any outflow tract obstruction, if the patient has a cervical fibroid, which prevents the easy flow of the menstrual blood through the vagina, so the patient can have a risk of developing endometriosis. What are the associated problems with endometriosis? Endometriosis related comorbidities. One is adenomyosis. As I said, the menstrual endometrial glands get deposited on the peritoneal surface, on the fallopian tube, on the ovaries, and they grow. And every month during periods, there is an activation, chronic inflammatory reaction happening, which is the reason for the pain. When this endometrial glands and stroma go seep inside the muscle layers of the uterine wall, they lead on to adenomyosis. That means this lead on to adenomyotic uterus. That means they get severe pain during periods, chronic pelvic pain, they are at risk of miscarriage, and they develop painful periods. This is most commonly associated condition with endometriosis. They can very rarely they can lead on to endometrioid ovarian cancers. Very rare, less than 1%, but there is a risk of endometrioid and ovarian cancer. They can be endometriosis can be associated with other autoimmune diseases like systemic lupus erythematosus, Sjogren syndrome, or multiple sclerosis or rheumatoid arthritis. These women are at risk of cardiovascular conditions like myocardial infarction or stent placement. So, how does it affect the quality of life? First, as I said, there is a risk of infertility. Around 30% women can have problems with conceiving. Second, because of the pain and heavy flow during periods, it can affect the quality of life. It impairs the physical, mental, as well as social well-being of a woman. During periods, they don't feel like working, they don't go to office, they keep lying down on the bed. It has a psychological effect, stress, anxiety, depression, all this. Plus there can be a low self-esteem, poor performance at work during these periods, and it might disturb their normal sleep pattern, poor quality of sleep, on top of fertility issues. These all the ways by which this endometriosis can affect the quality of life. Next, how do we diagnose endometriosis? Only the endometriomas seen in the ovaries are detected by scan. Many a time, microscopic deposits in the pelvic peritoneum goes undiagnosed by ultrasound. It is mainly a clinical thing. When you ask a question for the patient, clinical history is very important. Preliminary diagnosis, mainly based on the history taking, clinical history of the patient. Next, physical examination of the patient can give us a clue sometimes about endometriosis. Even the scan says everything normal. When you palpate, when we do a bimanual pelvic examination, When we feel uterine tenderness or adnexal tenderness or a fixed retroverted uterus, nodularity in the uterosacral ligaments, or a pelvic mass, we get a suspicion of endometriosis. But the actual diagnostic test is laparoscopy. Laparoscopic inspection with histological confirmation after biopsy is the gold standard for the diagnosis. But many a times, with a clinical history and clinical examination, we get a suspicion. Plus, ultrasound, pelvic ultrasound, vaginal ultrasound gives us an idea about endometriosis. If there are endometriotic cysts in the ovary, then we get to know with the ultrasound. Other investigations like MRI, CT scan can be done, but they add on information. But for diagnosis, basically, clinical examination with ultrasound will give us a clue about endometriosis. So for differential diagnosis, we might think as a urinary tract infection, we might think of a pelvic infection, or we have to do a pap smear test. So, as I said, endometriosis only it forms when it forms cysts in the ovary, it is detected in scan. Small pelvic deposits goes undiagnosed by scan. So, clinical examination, when the patient says pain during period, pain during periods, heavy bleeding during periods, everyone ignores, thinking that it's normal for every woman to have pain during periods and heavy bleeding during periods. Because of this common misconception that pain is normal in periods, the early diagnosis of endometriosis is missed. There is a delay in diagnosis of early stage endometriosis in women between the age of 18 to 45 years, up to an average span of 6 to 6.5 years. Even up to 6 years, we might miss diagnosing endometriosis when when they are in the early stages. So this leads on to unnecessary suffering and reduced quality of life of a woman. So whenever there is suspicion of endometriosis, early referral, early diagnosis, identification of the disease, and treating the condition can help prevent the disease progression as well as preserve the fertility. Non-invasive tools are there to diagnose endometriosis that can facilitate early diagnosis and intervention. So, how do we classify endometriosis? So, it is classified as stage 1, 2, 3, or 4. Stage 1 is minimal endometriosis, where there are very small superficial lesions on the pelvic peritoneum, on the pelvic side walls, or in the pouch of Douglas. Second is mild endometriosis, where there are superficial lesions up to 5 millimeters infiltration below the peritoneal surface. Stage 3 or moderate endometriosis includes endometrioma. As I said, the blood collection in the ovary forming a blood filled cyst, and minor adhesions between the uterus and the ovarian walls is stage 3 endometriosis or moderate endometriosis. And then stage 4 or severe endometriosis, where there are dense adhesions. Adhesions means the ovary, uterus, and the fallopian tube all sticking onto one organ. See, the menstrual blood has a tendency, not only menstrual, any blood outside the blood vessel has a tendency to stick on the organs altogether. So there can be severe adhesions between the bowel, the urinary bladder, the uterus, fallopian tube, ovary, and they might form a N mass like structure. That is stage 4 endometriosis. And there can be deposits or severe damage to the fallopian tubes, where the tube gets swollen, filled with fluid. There can be a severe damage in the pouch of Douglas. That is stage 4 endometriosis. How now we spoke about endometriosis. How does it affect pregnancy? How does it prevent a woman from conceiving? Infertile women are found to be 6 to 8 times more likely to have endometriosis than women who are fertile. Women with endometriosis have a low fecundity rate. Fecundity means the probability to pregnancy is always low in women with endometriosis than a woman who doesn't have endometriosis. So that means it reduces the chance of natural pregnancy. Endometriosis is again associated with a lower birth rate, live birth rate, because of adenomyosis. Associated adenomyosis, there is a high risk of miscarriage. How does this endometriosis affect fertility? It affects every step towards pregnancy because of the adhesions or because of the chronic inflammation, there is an increased oxidative stress because of the ovarian cyst. There is a change in the, because of the adhesions, there is a change in the normal tubal anatomy. There can be an altered immune function. There can be abnormal folliculogenesis. There can be a accelerated decline in the ovarian reserve. There can be a reduced endometrial receptivity. The uterine lining might not be ready to accept the embryo. There can be an altered follicular and peritoneal hormones. Every step possible, it affects fertility. Now, how does this inflammation happen in endometriosis? As I said, these peritoneal lesions, these endometrial glands and stroma, when they are deposited on the pelvic peritoneum, they lead to activation of the macrophages. Macrophages release inflammatory factors, reactive oxygen species, nitrogen species, cytokines, growth factors, and prostaglandins. Prostaglandins are one which causes the pain. There is a pelvic environment becomes very adverse because of the chronic inflammation in the peritoneal fluid. The oocytes quality comes down. The oocytes are damaged because of the local release of these hormones. This can lead on to infertility. So there is also an impaired progesterone signaling that exacerbates the problem. How does it do? It disrupts the progesterone and estrogen signaling. Because of this, it suppresses the cellular response to progesterone exposure because the receptivity to the progesterone exposure becomes less. So this hormonal imbalance leads on to high increased inflammation. Further worsens the inflammation, increases the pelvic pain, and reduces the endometrial receptivity. So, how do we manage infertile patients with endometriosis? So, medical treatment, surgical treatment. Medical therapy is essential for endometriosis. Endometriosis is impossible to cure. As I said, the recurrence rate is very high, but it's possible to arrest the development of the disease and reduce the symptoms. So the recurrence rate of endometriosis is very high. Even after surgical removal of the endometriosis, in a period of 5 to 7 years, there is a risk of recurrence in up to 55% of the cases. In 5 years, the recurrence rate is around 45 to 47%. In 1 to 2 years, up to 20 to 22%, there is a risk of recurrence. So the recurrence rate in endometriosis is high even after surgery. So this should be explained to the patient before you plan a surgery. Surgical removal of endometrioma is advocated only when the patient is symptomatic, when you are planning for an IVF, and if the ovaries are not accessible, then we plan a surgery for endometriosis. Or if we suspect hydrosalpinx, if there is a damage to the fallopian tube, then we plan a laparoscopy. And patient should be counseled that there is a chance of decline in the ovarian reserve after endometriosis. The new strategy favors conservative management or a medical therapy, with surgery suggested as a only option for cases that remain non-responsive to medical management. Which therapy should be preferred for early endometriosis? Endometriosis therapy should increase the quality of life and the reproductive health. When there is a minimal or mild endometriosis, it is difficult to diagnose by scan. Most of the time, patient presents with symptoms. They have heavy pain, bleeding during periods. They might have difficulty in conceiving. So we relieve or reduce the symptoms. Try to shrink the endometrial growths outside the pelvic peritoneum. Preserve the ovarian function and treat the endometriosis associated infertility, and then prevent, or if not possible, at least delay the recurrence of the disease. This is the main motive for medical management in early endometriosis. So what all medications we give in early endometriosis? First, we give either progestogens or antiprogestogen, NSAIDs for pain relief. Sometimes we do give contraceptive pills, GnRH agonists or antagonists, and aromatase inhibitors. So endometriosis therapy should focus on fertility preservation in women who is deciding for pregnancy. Women with endometriosis who are at risk of decreased ovarian reserve and ovarian tissue damage, which can lead on to infertility, reduced response to ovarian stimulation for IVF after the laparoscopy, it can cause premature ovarian failure. So, fertility preservation in women of the reproductive age group 18 to 40 years should be the focus of endometriosis therapy. Although many drugs are available for endometriosis, there are many unmet needs because when a patient has endometriosis, giving an oral contraceptive pill can reduce the chance of pregnancy. So, we need to find a medication which can give pain relief, doesn't affect your ovulation, as well as stop the process from growing further. So, dydrogesterone is a medicine which can be given orally, which can reduce the pro-inflammatory cytokines, it can reduce the oxidative stress, and relieve the endometriosis progesterone resistance. How do we give dydrogesterone? You can give either as a continuous regime for continuous 30 days or a prolonged cyclical regime. Dydrogesterone is given 20 to 30 milligram per day for 6 months, or a longer period is recommended for the management of endometriosis. It is only estrogen is of choice between two efficacious regime for endometriosis. And moreover, they have done studies where they found out that with this medication, there can be a reduction in the size of the endometrium. It can reduce the pain. There can be a 60% decline in the abdominal cramps and pain relief. It can reduce the severity of the bleeding. It can reduce the number of days of bleeding by about 90%. And moreover, it doesn't affect ovulation. Even after laparoscopic removal of the endometriotic lesion, patients can be put on this medicine, which can increase our chance for pregnancy naturally. In a young patient with mild endometriosis, they can be put on this medicine, which can increase our chance for natural pregnancy. So now going to the current medical therapies which are usually given for endometriosis, but they can prevent ovulation. They can delay the conception. It does not provide a fertile benefit after treatment. It can suppress ovulation. It cannot be used in women with who are planning pregnancy, and no evidence that medical therapy alone or in combination with surgery can improve the fertility. So there is a requirement of a therapy that can avoid the unnecessary side effects of contraception, as well as give the benefit of ovulation when it gives a pain relief for the patient. So as I said, oral dydrogesterone, it does not inhibit ovulation. It does not cause anovulation when it is used in a therapeutic doses. It does not affect the serum estradiol levels. It induces decidual transformation with a resultant necrosis and resorption of the endometriotic implant. It even shrinks the endometriotic implants. Estrogen add-back therapy becomes irrelevant because when we use dydrogesterone, there is no need for a estrogen add-back therapy. It improves the pregnancy rates as well by reducing the levels of inflammatory markers. It leads to activates the progesterone receptors, and which is necessary or a prerequisite for a successful pregnancy implantation to happen. So depending on the requirement of the patient, whether it is for a pain relief or for fertility, we treat the patient. And for minimal and mild endometriosis, we start with ovulation induction with intrauterine insemination. And if the patient doesn't conceive in 4 cycles of IUI, then we counsel the patients for IVF. Whereas with stage 3 and stage 4 endometriosis, advanced stage endometriosis, we counsel the patient for IVF because IVF gives the highest pregnancy chance with patients with endometriosis. In endometriosis, if we see that the tubes are swollen, that condition is called as hydrosalpinx. Then, if the tubes are patent, the fluid, the hydrosalpinx fluid which is collected in the fallopian tube, can seep inside the uterine cavity. It can affect implantation. It can flush the embryos. So it can reduce the chance of IVF success. So what we do is, if there is hydrosalpinx and it is documented by ultrasound or in laparoscopy it's confirmed, we disconnect or clip the hydrosalpinx so that the fluid doesn't seep into the uterus, and then go ahead with the embryo transfer. and they found out that the pregnancy rates are far better after clipping of the hydrosalping than with the hydrosalpings in situ. So the endometriosis is a chronic inflammatory condition which is very common in women of the reproductive age group. When it is detected early and properly treated, pregnancy rates are better. But in stage 3 and stage 4 endometriosis, when patient presents with severe symptoms, infertility, adhesions, hydrosalpings, in every step towards pregnancy, it can affect the fertility, and so these patients are counseled for IVF. As such, the IVF pregnancy rates are 5 to 10% lesser in patients with endometriosis compared to other reasons for IVF like a tubal factor or a polycystic ovarian syndrome. So, women with endometriosis, if they are diagnosed with mild endometriosis or a small 1 or 2 centimeter endometrioma, also, you should not ignore it because it can, because the risk of recurrence and the chance of the endometrioma growing further to a bigger size and worsening the condition is more. So, if you are diagnosed with endometriosis, patient should not delay pregnancy and start with the treatment as early as possible. Thank you. No questions. I'll end this session. Thank you.